While he comes here from the Finance Committee, we will be having members in and out throughout the morning because this is a very busy day for hearings in Congress. In fact, I have 3 this morning. You'll see people come and go. I do want to use this hearing to build a record for ways that we can save in the budget on healthcare costs. And so today's hearing is about excess costs in healthcare and ways we can reduce the budget by spending healthcare dollars more efficiently. As I point out often, and as this graph shows, the U.S. continues to spend more on healthcare as a percentage of GDP than any other peer OECD country. And at the same time, the vertical graph is life expectancy, and the average life expectancy in this country is lower than that of most of our peer countries, parallel to Estonia. We also spend more on healthcare per person, not just per GDP, over 1.5 times more than the next closest country, Switzerland. We're spending $4 trillion a year, and the Centers for Medicare and Medicaid actuary estimate that health spending will grow to 20% of GDP by 2031. Not only is our life expectancy in America lower than you'd expect compared to other OECD countries for all the money we spend, but it has actually declined over the last 2 years. An American's life expectancy is now the lowest it has been in 2 decades. We can do better than to be on par with Estonia, particularly when we're spending nearly double on healthcare as a percentage of GDP. Put very simply, we get very little bang for $4 trillion. It is grim, but there are some signs of progress, and we'll hear today from experts about how we can do better. CBO has found that federal health care spending between 2010 and 2020 was more than $1 trillion lower than CBO had projected prior to implementation of the Affordable Care Act. And as this chart shows, CBO now projects the U.S. will spend $4.6 trillion less on the major federal health programs, mainly Medicare and Medicaid, over the next decade than was projected pre-ACA. CBO also found growth slowed in spending per beneficiary. While there are many contributing factors, the deceleration shows that smart policymaking and reforms can help bend the cost curve. The Affordable Care Act fundamentally changed healthcare, and thanks to the payment modernization and care transformation it initiated, we're seeing reduced health spending. But our work isn't done. Notwithstanding Medicare's new power to negotiate the price of some drugs, thanks to the Inflation Reduction Act, Medicare spending continues to grow faster than the rest of the federal budget, and our national health expenditures are rising rapidly still. That's because our fragmented and endlessly complex healthcare system creates the perfect environment for inefficiencies to fester. It is where excess costs live and grow. Today, we'll hear from experts about 3 areas of inefficiency that have increased healthcare costs for patients, families, and the federal government, and I would add also increased frustration. First, we'll hear about the dizzying web of administrative tasks, the billing, the reporting, and all the non-clinical work incidental to the actual delivery of care that providers face. We'll hear how these burdens are responsible for over $500 billion in healthcare spending every year, and annoyances like prior approvals that I think for ACOs are not even necessary. Our discussion on this is especially timely. Research released last week revealed possible savings between $40 and $60 billion a year just from fixing the mess of healthcare billing and claims. Next, we'll hear about how consolidation in healthcare can raise prices for patients, leading to higher federal health spending. We'll also learn about potential solutions like health cost databases that don't just bring much-needed transparency into the opaque world of health prices, but also enable stakeholders to take actionable steps to control spending based on that data. 18 states, including Rhode Island, are already making use of tools like these, known as all-payer claims databases, to reduce patients' costs and improve care. Then we'll hear from one of Rhode Island's leading healthcare experts, Dr. Al Kouros, about how our fragmented health system, with patients often navigating multiple providers at different sites instead of obtaining care from a primary care provider, results in worse care at higher cost. We'll hear how delivery system reforms like accountable care organizations can promote higher quality care with less money spent. Patients seeking care are often lost in the maze of our current fee-for-service system. Transitioning to value-based care predicated on strong primary care can help achieve the long-sought triple aim of better care, better health, and lower costs. Within our current healthcare system, there is no doubt that value-based care is the best solution. Value-based care rewards providers not based on how much care they deliver for patients, but on how well they deliver it. A decade on from the implementation of the ACA, we have learned a great deal. We've learned that simplifying non-clinical work in healthcare, changing how we pay for healthcare, and transforming how we deliver healthcare can both lower costs and improve outcomes. If we do all of this more often and at scale, we can deliver the best and most accessible healthcare for America's patients. With that, I will turn to my distinguished ranking member, Chuck Grassley.
A very important subject of improving health care and lowering costs, and thanks to all of our witnesses for the time that you've put into the extra time you put into educating Congress and preparing for this. Health care might be one of the few markets in our economy where the consumer doesn't know the price before they buy it, and they rarely pay for it directly. Yet Americans spend more than $4.3 trillion annually on health care. Our spending has more than tripled as a percentage of gross domestic product since 1960. Growing health care costs don't just strain Americans' pocketbooks, they also are key drivers of widening budget deficits and the federal government's unsustainable fiscal outlook. And it's not clear that we're getting our money's worth for all that spending. Major health care programs spending eats up 32% of federal revenue today, and it will be 45% of revenue by mid-century. Our healthcare system has plenty of waste and inefficiencies that need fixing. Increasing transparency and competition, fighting fraud, and getting rid of red tape are some key areas to start with. You should know what something costs before you buy it. That's common sense for any consumer. That transparency is what we need. Until recently, we didn't apply sunshine to healthcare prices. I'm glad hospitals and health plans are now required to report their pricing data, but I'm not sure that it's in consumer-friendly ways in which it's put out, and may not be as effective as it was intended to be. More transparency should also be applied to pharmacy benefit managers, a very opaque middle people between pharmaceutical companies and the consumer. And I think this would lower patient and taxpayer prescription drug costs. Another way to lower healthcare costs is to ensure taxpayer dollars are being used wisely. Last year alone, our federal major healthcare programs lost over $130 billion to what we refer to around here as fraud, waste, and abuse. I'm the author of a major and more recent update to the federal government's most powerful tool in fighting fraud, the False Claims Act. And since I got that adopted in 1986, we have seen the federal government recover more than $72 billion lost to fraud and save billions more by deterring would-be fraudsters. We should also be reducing unnecessary red tape and administrative burden. Between 1975 and 2010, the number of physicians grew 150%, while the number of healthcare administrators increased by 3,200%. This administrative growth is driven by regulations which take more compliance time and financial resources away from patient care. We need policies then that promote the discovery of new cures and better treatments, not overly administrative price controls that stifle innovation. I worked for 5 years to allow the sale of over-the-counter hearing aids with Senator Warren of Massachusetts. Today, consumers can buy a pair of high-quality and safe hearing aids at $3,000 less compared to a year ago. I also support improving value in our healthcare system, but we need to accurately account for what's working and what's not working. Recently, the Congressional Budget Office found that the Center for Medicare and Medicaid Innovation, a program created with the goal of lowering costs, did not lower Medicare costs. Let me emphasize, that's not Chuck Grassley saying that. The Congressional Budget Office has said that. CBO says the program increased federal spending. I invited CBO to this hearing and look forward to learning about their analysis today. We should look to the market-based solutions similar to Medicare Part D, which I also led the team on Finance Committee to get adopted in 2003 because it lowers cost and improves care. In the first decade of Part D, the Congressional Budget Office found that this Part D program ended up costing taxpayers 36% less than projected. Finally, we can talk about waste and inefficiency in the healthcare system. We can't talk about it without discussing the country's fiscal situation. According to CBO, the federal budget deficit in fiscal year that just ended clocked in at about $2 trillion, and future deficits are projected to be even higher, partly because of growing healthcare spending. Healthcare spending can be made more efficient without compromising quality of care and reducing access, especially in rural America. I hope that we can build upon the ideas that we hear here today from this outstanding panel to address our country's fiscal challenges while also improving health care for Americans. Thank you.
Thank you very much, Senator Grassley. Our witnesses today are first Dr. Matthew Fiedler, who is the Joseph A. Peckman Senior Fellow in Economic Studies at the Brookings Institution, where his research examines a range of topics in healthcare, economics, and policy. Prior to joining Brookings, Dr. Fiedler served as chief economist on the staff of the Council of Economic Advisors, where he oversaw the council's work on healthcare, including implementation of the Affordable Care Act. We'll then hear from Dr. Limor Daphne. Dr. Daphne is the Bruce V. Rohner Professor of Business Administration at the Harvard Business School and Professor of Public Policy at Harvard Kennedy School. Professor Daphne's research focuses on competition and consolidation in healthcare markets. She previously served on the panel of health advisors for the Congressional Budget Office and was Deputy Director for Healthcare and Antitrust in the Bureau of Economics at the Federal Trade Commission. Then we'll hear from Dr. Al Kouros. Dr. Kouros worked as a practicing primary care physician in a community-based office for 20 years. In his second career as a healthcare executive and community leader, he's continued his focus on innovative approaches to how care is delivered and paid for. For 14 years, Dr. Kouros led Coastal Medical through its transition into an ACO and indeed a star performer in the Medicare Shared Savings Program. He'll be speaking to us today about lessons from that experience and the movement to accountable care that he and Coastal have been a part of. Next will be Mr. Theo Merkel, He is the director of the Private Health Reform Initiative and a senior research fellow at the Paragon Institute and senior fellow at the Manhattan Institute. Previously, he served as special assistant to the president for economic policy at the National Economic Council in the White House and served as legislative director here in the Senate for Senator Pat Toomey. Our final witness today is CBO's own Dr. Chapin White, the director of health analysis at the Congressional Budget Office. Dr. White first joined CBO in 2005 as a health economist and went on to serve as a senior health researcher at the Center for Studying Health System Change, as well as a senior policy researcher at the RAND Corporation before rejoining CBO in 2020. My hope is that this hearing sets a foothold or a foundation for bipartisan discussions on ways that we can move legislation to reduce the cost of care and improve the quality of care in the healthcare system. And I hope we can focus on that not only today, but in the months ahead as the committee continues to rely on all of you for your expert advice. Let me start with Dr. Fiedler. You all have 5 minutes each. Your full statements will be made a matter of record.
Chairman Whitehouse, Ranking Member Grassley, and members of the committee, thank you for having me here today. My name is Matthew Fiedler, and I'm a health economist and a senior fellow at the Brookings Institution. My testimony today examines ways that policymakers can reduce the administrative costs generated by interactions between healthcare providers and payers. These interactions, which include contract negotiations, claims transactions, prior authorization activities, and quality reporting, are costly. A reasonable estimate is that they generate administrative costs totaling around $500 billion per year, equivalent to about 11% of annual healthcare spending. Most of these costs are ultimately borne by consumers and taxpayers. Importantly, administrative activities can be valuable. Billing processes compensate providers for delivering care, prior authorization processes can help prevent delivery of inappropriate services, and audit processes can help uncover and deter fraud. So efforts to reduce administrative costs have to proceed thoughtfully. In exploring reforms, it's worth considering both targeted policy changes and policy changes that would affect a broader swath of provider-payer interactions. A good example of a targeted policy change is eliminating Medicare's merit-based incentive payment system, or MIPS. Under MIPS, Medicare scores clinicians in several domains, including the quality and efficiency of their care. Clinicians' payment rates are then adjusted up or down based on their scores with the goal of encouraging high performance. Much of the information used to score clinicians, particularly on quality, is reported by clinicians themselves, and practices are estimated to spend thousands of dollars per physician per year reporting to MIPS. Yet despite these large administrative costs, MIPS is likely not improving patient care. One problem is that clinicians can choose the measures they are evaluated on, which makes it hard to meaningfully compare across clinicians. Plus, past studies of programs like MIPS have found little evidence that they improve performance. Since MIPS appears to be generating large administrative costs but few benefits, there is a strong case for eliminating MIPS and, ideally, replacing it with something more effective and less burdensome. There are other targeted changes that could also reduce administrative costs with few trade-offs, such as reforming the process used to determine prices for out-of-network services under the No Surprises Act and reforming the risk adjustment methods used in Medicare Advantage. But my larger point here is that many seemingly narrow healthcare policy decisions affect administrative costs, and it is worth being attentive to those effects. Turning to broader reforms, one salient feature of our healthcare system is that providers must deal with a menagerie of public and private payers, all of which set different rules. This may be a key reason that administrative costs are higher in the United States than in many other countries, and it suggests that standardizing billing, coverage, or quality reporting processes across payers could help reduce administrative costs. Relative to the targeted reforms I just discussed, these approaches may offer greater savings potential, but may also present more significant risks and trade-offs. One target for standardization is the methods that providers and payers use to exchange claims information. Some have proposed creating a central clearinghouse that would accept claims from providers in a standardized format and route them to payers, similar to approaches used in some other industries and some other countries' healthcare systems. This approach would likely more fully standardize claims transactions than past federal efforts, which have focused on establishing standards to govern bilateral provider-payer interactions. The key challenge would be ensuring that the clearinghouse was well run, as a poorly run clearinghouse could have few benefits or even do harm. Policymakers could also consider trying to standardize the substance of some payer rules around billing, coverage, or quality reporting. This approach may have particularly great potential to reduce administrative costs, but at least in some cases, standardized processes might be less effective, whether because they are less tailored to specific payers' circumstances or just poorly crafted. For example, a standardized prior authorization process might be less effective in deterring inappropriate utilization, which could partially or even fully offset any administrative savings. Thus, the attractiveness of this type of standardization is likely to be highly case-specific. Quality reporting may be one domain where the balance of costs and benefits favors aggressive standardization, such as by requiring all payers to rely on a standard set of quality measures reported through a central clearinghouse. This approach might not only reduce administrative costs, but also make the resulting data more useful by increasing sample sizes and facilitating comparisons across payers. It is also questionable whether payers currently produce substantial value by tailoring quality measures to their specific circumstances, which may reduce the potential downsides of standardization. Thank you again for the opportunity to testify, and I look forward to your questions.
Dr. Daphne.
Chairman Whitehouse, Ranking Member Grassley, and distinguished members of the committee, thank you for the opportunity to testify to you today. My name is Limor Daphne. I'm an academic health economist with longstanding research interests in competition and consolidation in the healthcare sector. Currently, I am a professor at the Harvard Business School and at the Harvard Kennedy School. Previously, I was the Deputy Director for Healthcare and Antitrust in the Bureau of Economics at the Federal Trade Commission and a member of the panel of health advisors to the Congressional Budget Office. The U.S. spends a larger share of its GDP, over 18%, on healthcare than any other country. Studies show that high prices, not the type or quantity of services consumed, nor the health of our population, are the primary driver of higher U.S. spending. International comparisons also show the U.S. lags other leading developed countries on most dimensions of healthcare quality. My focus today is on healthcare providers, such as hospitals and physicians, who jointly account for half of our healthcare spending. As you are aware, government programs like Medicare set prices for provider services like hospital admissions. But the private sector relies on market-based prices, and those prices are high and growing. In the 90s, private prices were about 10% higher than Medicare prices. By 2012, they were 75% higher, and today, private insurers pay more than twice what Medicare pays on average for hospital care. While public insurance programs don't pay these commercial prices, there are significant federal budgetary implications of high commercial prices. High commercial prices mean high employer-sponsored premiums, raising the cost of the tax exclusion for employer-sponsored coverage. High commercial prices also impact the premiums and therefore the federal subsidies for enrollees purchasing subsidized plans through the health insurance marketplaces. Consolidation is a key driver of rising prices in the healthcare industry. Scores of studies find that mergers and acquisitions result in higher commercial prices, with little, if any, evidence of improvements in quality. In addition, Medicare's payment policy has driven some of that consolidation, in particular, acquisition of physician practices by hospitals. Providers assert that high commercial rates are needed to cover the cost of government-insured patients for whom care is reimbursed at lower rates, below their actual costs. This dynamic ignores the fact that costs are themselves affected by reimbursement. Economic research finds that hospital expenses fall when prices fall, and healthcare at the current pace of cost and price growth is untenable. I have 3 recommendations to offer today. First, establish a national all-payer claims database, or APCD, which contains insurance claims from public and private insurers. Currently, researchers and regulators can't track what's happening in order to understand where and why we are paying more. The industry is running circles around us, mining the data to their benefit and exploiting loopholes. And it's too important and expensive for us to be this far behind. The APCD could also be used by states if they wish to regulate commercial healthcare prices. Setting price ceilings or restrictions on price growth would not only address a symptom of consolidation, it would also prevent additional consolidation aimed at amassing market power to raise prices. Second, invest in vigorous antitrust enforcement through increased funding for the Federal Trade Commission and the Antitrust Division of the Department of Justice. While GDP increased in real terms by 55% between the year 2000 and 2022, the budget allocation to the Antitrust Division increased just 2.6%. If we are going to rely on private markets to deliver health care and on commercial insurers to administer the majority of it, we need regulators to help protect and promote competition in these markets. Third, align Medicare's payment rates across ambulatory settings. Stop paying more for the same healthcare services like routine office visits and lab work when they are delivered in hospital-owned practices or facilities. This preference not only increases Medicare and non-Medicare spending today, it fuels higher spending tomorrow because it drives more integration of hospitals with physicians and bolsters the market power of healthcare systems. Adopting any and ideally all of these recommendations would mitigate the root causes of our nation's high provider prices, prices that lead to higher employer-sponsored insurance premiums, lower tax revenues, higher subsidies for plans purchased through the health insurance marketplaces, and higher Medicare spending. I urge you to evaluate the recommendations closely as your decisions can help us to achieve higher value health care with a price tag the nation can afford. Thank you.
Thank you. I'll turn now to Dr. Kuros, and I will note that in addition to his full testimony being made part of the record in these proceedings, we're also going to accept into the record a letter from the National Association of ACOs and several ACOs, including Rhode Island's own Coastal and Integra, encouraging Congress to extend APM bonuses for physicians. So that will be made a part of the record without objection. Dr. Kuros, please go ahead.
Chairman Whitehouse, Ranking Member Grassley, and other members of the committee, thank you for having me here today to discuss the topic of managing the care of patients and the health of populations to reduce the total cost of health care. My name is Dr. Al Kuros. For the first 20 years of my career, I saw patients every day as a practicing primary care internist. For the last 15 years, I've worked as a healthcare executive and community leader on care transformation and payment reform. My North Star has been pursuit of the triple aim of better care and better health at a lower cost. From 2008 until last year, I served as the president of Coastal Medical, a large primary care practice in Rhode Island that transformed itself into a physician-led ACO that has been one of the top performers in the Medicare Shared Savings Program. I have three main points I'd like to make today. Number one, I believe that as an industry, we can transform how care is delivered and paid for in ways that will reduce costs and make things better for patients. In many cases, I'll argue that we already know what to do. Number two, primary care is the foundation of any high-performing healthcare system, and right now, primary care is in crisis and urgent help is needed. Number three, advanced primary care by itself is, in my view, necessary but not sufficient to sustainably achieve the triple aim. Continued movement away from fee-for-service and toward value-based and prospective payment models is needed, particularly for specialists and hospitals where more skin in the game is needed when it comes to value-based payment. The 2021 National Academy of Sciences, Engineering, and Medicine report on primary care concluded that ACOs achieved modest cost savings as well as improvements in quality and patient satisfaction. Smaller physician-led ACOs with a greater percentage of primary care physicians were the best performers, and Coastal Medical was one of them. On the poster to your left, the green line represents the average total cost of care for Coastal's Medicare beneficiaries from 2009 through 2019. You can see that upon entry into the Medicare Shared Savings Program in 2012, Coastal not only bent its curve for total cost of care, it broke it. An important question to ask then is whether learnings from the success of smaller physician-led ACOs like Coastal are generalizable to larger systems of care. I will argue that many of them are. Coastal's diabetes management program is a good example. In that program, select patients are equipped with glucose meters that use cellular networks to automatically transmit blood sugar results in real time to a multidisciplinary care team that then engages with the patient if and only if intervention is required for a high or low blood sugar. In the old model of care 10 or 15 years ago, a patient with a high sugar might have just written it down in their logbook and planned to discuss it at their next visit with their doctor in a couple of months. Now their phone is going to ring. And that proactive outreach by the care team to address the high sugar when it's happening may well prevent an emergency room visit or hospitalization that might otherwise occur a day or two later. Clinical programs like this go well beyond what I first imagined when we started the ACO work back in 2012. Generally, such programs have been the result of cycles of iterative learning, which have been a characteristic feature of many of the most successful ACOs. It is these types of lessons about delivering the right care in the right place at the right time that I'm referring to when I assert that in many cases we already know what to do. As I mentioned, primary care is in crisis. We have a perfect storm of an aging physician workforce, a shrinking pipeline of new PCPs, widespread physician burnout, and a large cohort of baby boomers aging into Medicare. Workforce initiatives such as those coming out of the HELP Committee and improved compensation of primary care physicians are important next steps. I believe we also need to continue experimenting with expanding the primary care team and to pay more attention to understanding and mitigating physician burnout. Finally, primary care capitation as a payment model may help to take primary care teams off the hamster wheel of back-to-back visits all day, every day. In closing, I will reiterate my initial plea for more value-based payment for specialty and hospital care. Primary care cannot go it alone in this domain and sustainably succeed. That said, I remain cautiously optimistic because I believe that in many cases we already know what to do. Thank you.
Thank you, Dr. Kouros. Mr. Merkel.
Thank you, Chairman Whitehouse and Ranking Member Grassley, for convening this hearing and giving me the opportunity to testify. The federal government spends more money in healthcare than any other area, exceeding $2 trillion in 2022. For context, this is now over twice as much as is spent on defense. The pace of growth is unsustainable. The CBO projects healthcare to absorb a larger and larger portion of GDP for the foreseeable future. Perhaps most problematic, we do not get a good return for our money. For instance, Washington actually spent more on improper payments for healthcare, $150 billion last year, than proper payments for the Supplemental Nutrition Assistance Program, housing assistance, or transportation infrastructure. A widely cited study by the National Academy of Medicine estimated that 30% of all U.S. health spending does not actually improve health. Last year, the OECD compared health spending in developed nations and confirmed that the U.S. spends more on just about everything. But the key contributors to our outsized health spending are payments for hospital and physician services. Ironically, given last Congress's action on drug prices, we actually spend proportionally less on retail pharmaceuticals than every G7 country but the United Kingdom. Well-intentioned but ultimately counterproductive government policies increase prices and health spending by both inflating demand and decreasing supply haphazardly. First, far from being parsimonious with our federal health care programs, we are one of the only nations that subsidizes health care largely without limit. If Medicare is billed for a covered item or service, it will pay it. If a state makes a Medicaid expenditure, Washington will match it. If insurers selling Affordable Care Act plans raise premiums, the federal taxpayer covers the increase. No matter how generous a health plan an employer chooses, it receives a tax break. Ultimately, we generously subsidize care that Americans need, but we also subsidize a lot of inefficient care and waste. Second, federal and state policies limit supply by restricting who can provide health care items and services and where they can provide them. This insulates providers and suppliers from competition, allowing them to command higher prices and remain inefficient. It also severely limits innovation as it gives incumbent providers bureaucratic and political tools to prevent the type of disruption that we have seen in other sectors of the economy. With only a few exceptions over the past several decades, Congress has either exacerbated these two fundamental issues or just tried to work around them with top-down approaches that rely on government technocrats to try to manipulate the system into efficiency. We are here today because those efforts have largely failed. Given its size and importance, Medicare is often the epicenter of the policy debate. Since 1983, the reform of choice has been price controls, starting with hospitals, moving to physicians, and recently moving to prescription drugs. But price controls largely just attempt to approximate the cost of providing a service or producing an item. They avoid whether that service or item should be provided and the value that it may offer relative to alternatives. Simultaneously, despite the best efforts of the Center for Medicare and Medicaid Services, price controls are inevitably inaccurate and hugely distort how care is delivered and where investment flows. The Affordable Care Act put faith in a similarly top-down approach that an entirely new agency of well-intentioned bureaucrats insulated from congressional meddling would be able to engineer better payment methods. Yet, the CBO recently found that after a decade of work, the Center for Medicare and Medicaid Innovation managed to add to the deficit. Fortunately, there are many ways to reduce wasteful spending while not reducing benefits on enrollees. I have a list of proposals in my written testimony, but to highlight a few principles. 1, shift financial risk away from taxpayers. This does not mean we need to shift risk to beneficiaries. It could be ACOs, other providers, insurers, states, or others. But our major healthcare programs should no longer simply write blank checks. 2, get the government out of the business of dictating who should be paid how much and where. Site-neutral payment reforms being discussed in Congress would be a good incremental step. 3, favor bottom-up solutions like enabling patients and employers through more coverage options and price transparency instead of the top-down approaches that have repeatedly failed over time. Thank you again for inviting me to testify, and I look forward to your questions.
And finally, Dr. White.
Chairman, White House, Ranking Member Grassley, and members of the committee, I appreciate the opportunity to appear before you today. In consultation with Budget Committee staff, I focused this testimony on accountable care organizations, CMMI, and the unexpected slowdown in federal healthcare spending. Because ACOs voluntarily assume responsibility for the quality and cost of care for a defined group of patients, they have the potential to reduce unnecessary care, improve care coordination in patients' health, and reduce spending. Healthcare providers participating in ACOs or other value-based payment arrangements receive financial incentives to improve the efficiency and quality of care. Such incentives contrast with those found in Medicare's traditional fee-for-service program, in which separate payments are generally made for each encounter or service delivered. Fee-for-service, as many observers have pointed out, tends to create incentives for providers to deliver additional and more complex services. CMMI's goal is to identify approaches that reduce spending or improve the quality of care, and to do so, it operates models that test new ways to deliver and pay for healthcare, including models that establish value-based payment arrangements. The ACA established a permanent ACO program in Medicare known as the Medicare Shared Savings Program. CBO has reviewed the evidence on the performance of the MSSP and found that the program was associated with small net budgetary savings in the early years of its operation. The more recent evidence is somewhat limited and challenging to interpret. It's become more difficult to find reasonable control groups to use, and providers have the ability to opt in and out of the ACO program. What were CMMI's budgetary effects over its first decade of operation? As other folks have previewed, CBO has updated its estimate of the budgetary effects of CMMI and currently estimates that CMMI's activities increased direct federal spending by $5.4 billion, or 0.1% of net spending on Medicare between 2011 and 2020. Specifically, CMMI spent $7.9 billion to operate models, and those models reduced spending on healthcare benefits by $2.6 billion. That estimate reflects CBO's review of published evaluations of 49 models initiated in CMMI's first decade. In terms of CBO's projections of CMMI's effects over the current baseline projection period from 2024 to 2033, CBO projects that CMMI will increase net federal spending by less than $50 million, which is a star in CBO's tables. Over that period, the estimated effect of CMMI's activities transitioned from an annual net increase to an annual net decrease, reflecting ongoing growth in the number of certified models that continue to produce savings over time. Legislative proposals that would affect CMMI could fall into one of three categories: modifications to specific models, changes to the parameters within which CMMI operates, and a repeal of CMMI's statutory authority or rescissions of unobligated funding. In general, CBO would analyze the specific evidence on specific models if the legislation related to a specific model, or when data are not available or the legislation is more general than that, CBO would rely on a general framework using information on CMMI's prior activities and performance. And as always, the estimated effects would depend on the details of the legislation. So, have alternative payment models contributed to the slowdown in healthcare spending? The implementation of MSSP and the creation of CMMI have occurred during a period of unexpectedly slow growth in federal healthcare spending. Whether that slow growth is related to CMMI or other alternative payment models created under the ACA is not entirely understood, but CBO's review of the effects of the MSSP and its estimate of the effects of CMMI in its first decade of operation suggests that they together were not factors in that broader slowdown. Still, some researchers have posited that the existence of CMMI may have led to broader system-wide changes that are not attributable to a specific model. Over the past decade, CBO has been tracking the slowdown in federal healthcare spending and has previously pointed to several contributing factors. Broader factors include decreases in the growth of Medicare's payment rates, reduced spending on patients with cardiovascular disease, and a shift in the relative importance of technology in fueling the growth of healthcare spending. Federal spending on Medicare and Medicaid programs also grew more slowly than CBO projected. A key factor underlying Medicare's slower than expected growth was slower growth in net spending on prescription drugs. For Medicaid, a key factor was less than anticipated spending for long-term services and supports. Those are my prepared remarks.
Thank you very much, Dr. White. Let me start with Dr. Kouros. You and I lived through, me much less so than you, all the difficulties of transitioning Coastal Medical to an ACO and to a very successful ACO. But if you look through all those difficulties to the experience of your patients at the end of the day, how do you evaluate Coastal Medical's patient experience as a result of the successful transition?
As somebody who practiced primary care for 20 years and ended that part of my career just as the ACO movement was really getting up and running, the things that I've seen happen at Coastal for patients really go way beyond what I could have imagined. There's a whole variety of centralized clinical programs that improve access to care, timeliness of care. There are disease management programs for specific chronic conditions. There are primary care urgent clinics, nights, weekends, holidays. There is a whole multidisciplinary team available to many of our patients with members of the team, including clinical pharmacists, social workers, navigators, co-located behavioral health providers. And so I look at the movement to accountable care as really being the impetus to allow that great expansion of services to really deliver a level of care that we just couldn't do when I was in practice.
So in order to save the millions for Medicare that Coastal has saved, you were not obliged to cut benefits to your patients. Indeed, they saw new and improved services.
Yeah, I think that's an accurate statement, and we have sort of a truism that we repeated often at Coastal, which is that you have to spend more to save more. So you have to invest in the human and technology infrastructure to really be able to execute on population health management if you want to be able to deliver the kinds of services that we're talking about. But it was the alternative payment models inherent in the ACO model that allowed us to generate that additional revenue, which we then reinvested to fund all that clinical programming, which ultimately improved efficiency, improved care, reduced total cost of care.
The bureaucratic system did not always entirely support that transition. One of the things that I think makes sense in a fee-for-service system is prior authorization, just to keep billings from going through the roof. But once there is, as you say, skin in the game, the rationale for prior approvals in a value-based system appears to diminish, if not entirely evaporate. Were you obliged, nevertheless, to continue to seek prior approvals? And if not, where not, and was that a success?
We certainly did, and Coastal still does see requirements of that type. The sort of interim solution at Coastal was to create teams of people who could assist providers in that process so as to reduce the administrative burden and the time commitment to that particular aspect of the work. But I agree completely with the underlying thesis that when you incent provider organizations to be accountable for total cost of care, then a lot of those, once you have that construct in place, then you may not need to have all these administrative processes. One thing that I'll add is that it's important as we try to build out and execute on these constructs that we remember that the payment model that an organization sees has to be translated into an aligned compensation model for physicians if you really want to lock in that mindset that we're counting on to sort of control avoidable spending and improve efficiency. So knowing that there's alignment between organizational payment models and physician compensation, I think, is important if we expect to see the kind of outcomes you're alluding to.
Last point, if I'm building a house or doing a major renovation, I hire a general contractor to manage the project for me, and I expect that general contractor to intermediate with electricians, drywall folks, carpenters, all the specialists who do the work of bringing the project to a successful conclusion. Is that the way primary care presently works? And would it be useful to try to put primary care providers into more of a general contractor model so that they can intermediate between the patient and the specialists and coordinate care more effectively to the benefit of the patient?
So that's an interesting analogy, and I think that there is a key role for primary care physicians to coordinate care when a patient has multiple complex conditions and requires the care of multiple specialists. I'm not sure all my specialty colleagues would like the general contractor analogy so much, but I think if we could at least agree that what we need is regular communication. And I think the other thing that primary care docs are uniquely positioned to do is to have a deeper understanding of what the patient's own priorities and goals of care are. And in that context, the primary care doc can really help to shepherd the care of a patient through what you alluded to earlier, I think correctly, as a very much fragmented system still and highly complex. For those of us who work in healthcare, even when we have to help a family member try to navigate systems, it's even inside baseball players find it challenging at times. And so I think that's a really important aspect of the role of primary care that we need to preserve and expand.
Senator Grassley.
Thank you, Mr. Chairman, and thank you all for your testimony. Common sense supports all of us wanting to get more value out of our healthcare system. I was proud to lead the effort to implement Part D nationwide prescription drug benefits for seniors a long time ago. We used a market-based approach. Competition, access, and affordability has been key hallmark of Part D programs. And I think it, compared to what figures were given by CBO at that time, it turns out to be a good steward of taxpayers' dollars. In the first decade, saving 50% less than CBO projected. So, Dr. Merkel, what can we learn from Medicare Part D to apply to other federal health care programs?
Thank you for the question, Ranking Member Grassley. One of my key takeaways from Part D is there is often, especially with entitlements, perceived unnecessarily to be this tension between providing benefits and getting value for both beneficiaries and taxpayers. And I think Part D has been able to show that this tension does not need to exist. How did it do that? It mandated benefits, but it also required that financial risk be shared between taxpayers through Medicare, but also other entities, which are Part D plans. And very importantly, for accountability, the accountability of Part D plans is not just to the government or bureaucrats, but it's also to beneficiaries through choice. They can choose plans or switch plans if they're unsatisfied with the coverage options, and plans compete for beneficiaries. The result has been seeking high-value care. There has been high utilization of generic drugs. The United States has higher utilization of generic drugs than many of our international competitors. That's in part because of the way that Part D works. It's come in under budget, as you've noted, not just in the first decade, but as Dr. White noted, it's come in under budget again this most recent decade, and there's high beneficiary satisfaction.
Yeah. Dr. White, let me lead in with this about the Center for Medicare Innovation, Medicaid Innovation as well. Receives $10 billion of mandatory funding every decade. Despite this investment, CBO has found that CMMI has not lowered Medicare spending. Separately, CBO has found that Medicare Shared Savings Program was not a factor in slower growth of federal health care spending. Are these models that I just referred to validated by independent third parties to determine if they saved money? And in addition to that question, if there are independent analysis, what do they say?
Thank you, Ranking Member Grassley, for the question. First, I want to clarify on CMMI, the CBO's conclusion was that it added on that to federal spending, and other researchers have come to the same conclusion, including Brad Smith, who's a former CMMI administrator. Health Management Associates did a study, Avalier did a study. So CBO's conclusion on CMMI is generally in line with the consensus. On MSSP, CBO's conclusion was that it appears to produce net savings, and the evidence is fairly clear from the early years of the program. The evidence is a little harder to interpret in more recent years, but that conclusion that the Medicare Shared Savings Program has produced small net budgetary savings is consistent with and partly based on what outside researchers have said. So I think when I said that CMMI and MSSP were not a factor in the slowdown, it's more to say that CMMI over the 2011 to 2020 period added a bit to federal health spending. MSSP had net savings together. They were not a factor in the fairly large slowdown during the 2011 to 2020 period.
Mr. Chairman.
Senator Van Hollen.
Thank you, Mr. Chairman, and thank all of you for being here. Dr. Daphne, I'm going to start by asking you a question related to the collection of data. For many years, my state of Maryland has run an innovative payment model that started with regulating hospital pricing in the 1970s and now includes all-payer global budgets for hospitals in the state with incentives to reduce total cost of care and improve efficiency and quality of care. So far, the model has been meeting the Medicare savings goals and improving care. As part of this work and its ongoing work on pricing, rate setting, and global budgeting, Maryland's all-payer claims database has strong hospital-based data. However, as you noted in your testimony, many states struggle to obtain data on ERISA plans because these plans are regulated by federal statute, and the Supreme Court barred states from requiring self-insured plans to submit data to address state databases, making obtaining plan data more challenging. How does greater access to claims data help regulators and policymakers address costs and health equity issues? And will the HHS pricing transparency rules for insurers help fill the gaps in price information that many states experience, or are additional steps necessary to make sure that they have the information that meets their needs?
Thank you, Senator Van Hollen, for the question. And also, thank you to the state of Maryland for running some very impactful experiments for us researchers to study and to act as a laboratory for other states.
Got a Medicare question, too.
You asked me, how does it help for us to have access to a national all-payer claims database? It helps enormously because we cannot study the effects of mergers and acquisitions without health insurance claims. Right now, we rely on the largesse and interest of commercial insurance companies. That interest has been waning. And in order for us to assess the implications of a range of phenomena, including private equity consolidation, including the expanded geographic footprint of hospital systems, we desperately need access to these data. You mentioned the critical reason for the federal government to act, and that is because of that 2016 Supreme Court decision that ruled that states cannot compel self-insured plans, which are regulated under ERISA, to supply their claims data. So we really need your help to enable an all-payer claims database. And finally, you asked whether current efforts on price transparency are enough. And my answer to that is simply no. The transparency that is out there now, and that's for two reasons. One is that what is transparent now, to the degree that it is transparent, as Senator Grassley mentioned, there are a lot of issues with how it's being reported, is just price. And in order to understand our nation's spending, we need quantity too. So we have the prices for every possible, or could theoretically have the prices for every possible combination of service, insurance plan, and provider, but we don't know how many of those triplets are actually being delivered. And without any access to information about the quantity, we're swimming in the dark. And a second reason is that that data has been extremely difficult for researchers to assemble because it is spread out in a range of places and not uniformly reported.
I appreciate that answer and look forward to working with you and others to try to address this issue. Dr. Fielder, a question for you about hepatitis C, but especially prescription models. And hepatitis C is a growing disease with a rate of reported acute cases increasing 400% between 2010 and 2020. There are approximately 2.5 to 3 million people living with the disease. It also has lots of side effects that lead to other complications, but it is now curable with oral direct-acting antivirals. However, even with the competition and generic drugs in the market, the cures can be incredibly expensive, $24,000 or more for a course of treatment. Louisiana, with the support of CMS during the previous administration, implemented an innovative subscription model wherein they negotiated a bulk price in order to get unlimited doses of medication for Medicaid and incarcerated patients, and they also set up a screening and prevention program. My question to you is, do you agree that that subscription model can work generally for diseases like this, and specifically, how can we at the federal level learn from that with respect to hepatitis C?
Thank you for the question. So I think it generally can make a lot of sense for a payer to offer a manufacturer a somewhat larger total payment in exchange for a much lower per dose price that facilitates broader access. And I think a subscription model, as we've seen in Louisiana, can be a very good way of achieving that. I also think that there's a particular logic to the sort of federally run subscription model that's currently being discussed in the hepatitis C context, given where some of the access barriers we've seen here have come from. There's something of a collection action problem among payers, where society as a whole would be better off if there was broad access to these drugs and we avoided the downstream complications and new infections that come from active infections. But since people bounce from payer to payer over time, no particular payer is really that motivated to be the one who makes the upfront investment in identifying cases and treating them. I think it's also relevant that Medicaid is an important payer here, and historically it's been a fairly stingy payer across a variety of domains, and we've seen that specifically in the domain of sort of the coverage policy states have adopted with respect to hepatitis C. So against that backdrop, I think having the federal government adopt a subscription model with respect to hepatitis C and then make the drugs available at very low cost to Medicaid or other potential payers has a strong rationale.
Thank you. I appreciate that. And we may draw upon your expertise. We're in the process of putting together legislation on that initiative. Thank you, Mr. Chairman.
Thanks, Senator Van Hollen. Senator Braun.
Thank you, Mr. Chairman. The amount of time I've spent on this issue before I got to the U.S. Senate is a lot. I ran a business that exactly what we're talking about became the biggest issue once it was of a scale where it made a difference, and that started occurring back in 2008. I was finally sick and tired of hearing how lucky I was that my premiums are only going up 5 to 10% a year. That's the way you measure it in the real world. In a system that's built upon remediation with a very inelastic demand once you get sick or have a bad accident, with nearly zero consumer involvement, there's easy to understand why we are where we are. It was pointed out, and I think very well in both opening statements, we're at that place where it's a tapeworm on the economy. The providers are the same, whether it's a government payor or a private system payor. So unless we fix the underlying system, don't expect much to change regardless of what we do here, because you can't, when it's that big a part of your economy, it's not free market. It's like an unregulated utility. If you want to really see what we've got as a healthcare system, until we get our consumers engaged on primary healthcare with their own skin in the game, for the ones that can afford it, you're probably going to have a system for those that can't, because I think in this country, everybody ought to deserve good health and well-being, but we've got a monstrous system that we've evolved into. I'm going to hope we have, with the number of people here, a second round for questions. Do you think that looks possible, Mr. Chair?
It depends, but possible.
Okay. So I'm going to start here. The largest sector of our healthcare economy is now hospitals, large corporate hospitals. Back as recently as 10 years ago, that was maybe a third. Practitioners, doctors and nurses were about a third. And the balance being split between insurance companies and pharma. Now, hospitals are just under 50%. The number of doctors I've spoken to that regret that they've gotten into the business because they wanted their own enterprise. They never imagined working for a big company because they had to due to the arithmetic of their business. I'm simply asking for one thing, that is transparency throughout the system like we have in all other markets. Get rid of the barriers to entry that we've created here in government, helping hospitals, keep doctors from owning their own hospitals and things like that. But I think that's where we need to focus. Secondarily, it'd be insurance companies because they work together in an opaque system. So I've had a couple amendments. One recently would direct CMS to publish a list of hospitals not in compliance with the price transparency rule that went through the court system to even get out there. That was done during the Trump administration. The other requires hospitals and insurers to share specific prices they negotiate across plans. Mr. Merkel, got a question for you. What other reforms should Congress consider when trying to take the biggest part of healthcare that is more and more corporate, embraces none of the aspects of free enterprise? Do you like those ideas, number one? And what else can we do that would start to crack at least where most of our healthcare dollars are being spent currently?
Thank you very much for your question. I think that you have hit the nail on the head with your diagnosis of the problem. We're limiting supply at the same time that we're increasing demand through federal programs, and we are not enabling consumers and employers because we've just put them in the dark. I would absolutely start with what you have said, giving consumers and employers price information to basically, we have left these powerful tools on the table, which are consumers and employers seeking the best value for themselves. And as you have noted, unfortunately, what we did in the Trump administration, the compliance has been inadequate. So the legislation that you have put forth to codify those rules, and I think increasing enforcement mechanisms to require them, as well as being clear who is being transparent and who is not, would go a long way.
One brief follow-up question, and I'd like this to be answered by Dr. Fiedler. Obamacare gave us, I think, some things that addressed the fact that everybody should have access. It should be at a price that you can afford. What about some of the things that have been dysfunctional? Like, I think what came from that, too, was that doctors cannot own outpatient hospitals, nor can they grow ones that were in place. Is that something that ought to be changed? Why was that ever done in the first place?
So I do think there were provisions on limitations on physician-owned hospitals. I am generally of the view that I think consistent with the question you're asking, that there's not a strong rationale for limits on the entry of new hospitals into hospital markets, and in particular limits on who can own those hospitals. I frankly think this is probably not the sort of main contributor to why hospital markets are as consolidated as they are. I think it's probably a fairly marginal factor, but I don't think I think the underlying rationale is that physician-owned hospitals may do a certain amount of cherry picking in terms of the patients they treat, and so other hospitals were concerned that they would be left holding the bag. I don't view that as a particular concern, and I think there's unlikely to be much harm done by removing some of these restrictions.
Thank you.
Senator Marshall.
All right. Chairman, thank you so much for hosting this hearing. My first question is for Professor Fiedler. Fiedler, probably. My bad, Fiedler. Right? Okay. Prior authorization is the #1 administrative concern to physicians. It adds to their burden of their day, having a patient scheduled for a hip replacement, having them in the preoperative area, and then finding out that the insurance company has not done the final prior authorization for that particular process. I'm assuming you're familiar with prior authorization and how it's being used to ration care. What is the prior authorization impact, do you think, on healthcare expenses? Does it actually slow down? Does it make it worse? Any thoughts on prior authorization?
So I think prior authorization is very much a two-edged sword. On the one hand, I think exactly what you're talking about, it can create a lot of administrative hassle, both for providers, but frankly for patients as well, right? If you're the patient in that situation where the prior authorization hasn't come through, that's a very real burden. I think the flip side of this is there are cases where prior authorization is used appropriately, and we have evidence that it meaningfully reduces use of inappropriate services and therefore reduces claim spending and premiums and cost sharing for patients.
Appreciate that. I think you'd agree with me that if there was a streamlined, consistent process, that would be very beneficial to both sides of that coin.
I think there likely are opportunities to streamline these processes, and that's a fruitful place to explore.
Okay, I'm going to go to Mr. Merkel next, and kind of following up with Senator Braun's questions regarding the physician-owned hospitals. I may be the only person in the Senate Congress that's ran a hospital, owned a hospital, a private practice, oversaw health departments. I understand healthcare, pretty good. I always thought to drive down the cost of healthcare, we needed more transparency, more innovation, and consumerism, making patients consumers again, promoting competition. Whether it's insurance companies or whether it's hospitals, PBMs, we've seen this huge consolidation of the industry, partially because of overregulations. And basically, there is a moratorium on physicians to expand their hospitals or to have any new ones as well. I would brag on the physician-owned hospital. They have better care, much better quality of care. They actually give away more care than most nonprofits do as a sense as well. In our particular case, we were the only hospital within 60 miles with a level 2 emergency room. So we took all comers. So, Mr. Merkel, what was your experience with physician-owned hospitals, and do you think that they would help drive the cost down or up at the end of the day?
Thank you for your question, Doctor. I think that, with fee-for-service reimbursement and our entitlement programs being basically unlimited in how much taxpayer money that they will provide, Congress over the years has tied themselves into a lot of knots on how to try to protect taxpayers while in that system. And industry incumbents take advantage of those concerns and will utilize those fears to try to block competition from things like physician-owned hospitals or through certificate of need laws. I think both of those restrictions come from the same concern and demonstrate how industry incumbents basically use them to prevent competition.
Great. I'm going to finish up with the question, how much time we left. We'll see if we get through as many people as we can. We'll start with you, Dr. Daphne. I'm certainly a believer that our country needs a bigger investment in primary care. Everybody, if you have a heart attack, if you're in an automobile accident, you go to the emergency room, you're going to be taken care of, but we don't have as much meaningful access to quality primary care. Maybe we're spending half as a percentage of investment that many other countries are. Dr. Daphne, what do you think the impact of more primary care would do on the overall cost of health care, the overall expenses of health care?
Thank you for the question, Senator Marshall. I would say that relative to other countries, we spend far less on primary care than they do, and that results in pushing more spending to specialists whom we know are more expensive. I think it would be a tremendously valuable thing. We ought to look at the compensation for primary care specialists relative to specialists and to encourage more entry into that field, and would defer to the primary care physician to my left, should you want.
Dr. Croce, please go ahead. It's okay.
I concur with all that, and I think that particularly given the complexity and fragmented nature of our healthcare delivery system writ large, it's never been more important for patients, particularly with complex or chronic illnesses, to have a primary care physician that can help guide them through that system, make decisions, coordinate everything, and have them stay on top of things. And to me, that's foundational for a high-performing healthcare system of any kind.
Great. Certainly, I concur that in an instance, we're certainly thinking that community health centers are a big part of that, an opportunity where you can deliver health care to where the patients are, adding mental health support right there, nutrition coaching, those types of things. And since there's no one else standing in line, Dr. White, what do you think about more primary care, how that would impact the cost of health care for this country?
We have spoken to a number of experts about alternative payment models and ACOs, and they have pointed out that primary care is really central to ACOs in a very kind of nuts and bolts sense. To get patients attributed to an ACO, they have to be receiving primary care services. So that's kind of foundational. But there's also this phenomenon that physician-led ACOs are clearly more successful on reducing spending than hospital-led ACOs. And
imagine that.
And what we've gathered is that the physician-led ACOs tend to focus on shifting care away from facility settings, specialty care, imaging services, and so I think that's generally consistent with what you're saying.
Yeah. Thank you, Chairman. I yield back.
Thank you. Senator, while you were in your other hearing, we also had a bit of a conversation about prior authorization, and Dr. Kuros, and I think with other heads nodding, made the point that when you're in a fee-for-service system, there is some rationale to prior authorization to prevent just piling on with the billings. But once you move to a value-based system, like accountable care organizations run, then the logic, the rationale for having prior authorization diminishes, if not evaporates. So I appreciated your questions about prior authorization. I wanted to fill you in on what the prior testimony had been, and I do think that there's room as we move towards more value-based care in our healthcare system to make sure that the bureaucracies keep up with that, and you're not running legacy prior authorization systems that require doctors to maintain administrative staff that serve actually no real purpose because you've reoriented the incentives so that it really doesn't make sense to require prior authorization. Maybe there should be prior approvals for prior approvals.
We used to have that. So I certainly agree and concur that we need to go to these value-based models, and it would eliminate some of the need. But in the meantime, 90% of the healthcare system is going to fight that. And it'll take years to see that happening, and I think it's all the more important that we lean in as some type of a streamlined fix to the prior authorization issues, rather than punishing the 98% of physicians that are doing the right thing, and focus on those folks that who are indeed are abusing the system. So thank you. I appreciate those comments.
And I'm now delighted to recognize Chairman Wyden, who has stepped out of the Finance Committee briefly to join us. Thank you, sir.
I thank my colleague, and this is a very good hearing. And particularly, what we're trying to do in the Finance Committee is look at ways for the future to build around some of the things that just are common sense. For example, in the PBM area, we're looking at reducing the role of middlemen. I just came from the Medicare, hearing, and these marketing middlemen, based on today's numbers, are taking $6 billion out of the system. $1,300 a patient just on marketing. So I want us to look at the promising models, and that's what Chairman Whitehouse has given us a chance to do today. And I want to explore with all of you, I'll probably start with you, Dr. Kuros, chronic care. When I was director of the Gray Panthers, which has now been maybe a year or two ago, as I've been saying, Medicare was an acute care program. It was, you broke your ankle, and then you went to the hospital, and that was Part A of Medicare, and you had a horrible case of the flu, you went, saw your doctor, that was Part B of Medicare. That is not Medicare today. Medicare today is overwhelmingly chronic care, cancer and diabetes and heart disease and strokes. And people who have 2 or more of these conditions is now dominating the program. And before he retired, Chairman Hatch worked with us, and Senator Whitehouse remembers this, on a bill to say, we're going to ensure those acute care services are there, but we're going to start building around chronic care. And we passed a transformational chronic care bill, which included the country's first really big investment on the health side in telemedicine in terms of laying out the infrastructure. So we passed it, and one day I was sitting in my office after Chairman Hatch had moved on to other matters, and the Trump administration called and said, how would you feel about our using the telemedicine provisions as the basis for telemedicine services in COVID? And I said, you're asking me how I feel? This is the coolest day I can remember. I've got the administration asking me about something that Democrats and Republicans care about. And that, in fact, was how we delivered COVID-related services to a great extent during the pandemic, is using our telemedicine approach. So if you would, tell us why, because I understand you've been interested in this field, why you think that chronic care coordination and building on these kind of models makes sense.
You know, I think when we look at segments of the patient population that are older with multiple chronic medical illnesses, they certainly have an outsized impact on the total cost of care for the broader population. And I think there's an opportunity to really both control costs and improve patient experience, patient outcomes, efficiency of care. I think what you're alluding to in terms of acute versus chronic illness goes to some extent to the distinction between sort of reactive care models and proactive care models. And I think when you can have a proactive, team-based approach to the care of chronic illnesses, experience is just demonstrating how effective that can be. The timeliness of it is important. When you're proactive, you can often diagnose a problem earlier when the interventions that are required to restore wellness to the patient's condition, it's much more effective when you intervene early. So right care in the right place at the right time is a big piece of chronic illness management. It's also an opportunity, as I alluded to earlier, to incorporate the patient's values and their goals of care. When you have an engagement with a patient with multiple chronic illnesses, a very important part of that is to understand that aspect of their care and give them agency as patients and decision-making power. And often that will actually allow you to avoid unnecessary care or care that the patient never wanted. So I think that those aspects of chronic care delivery are very much incented and facilitated in an ACO model like the Medicare system.
My time is up, and I just wanted to say to you that we'll be back to you because there's really two issues here. One, Senator Whitehouse and I have been very involved in trying to update the Medicare guarantee. You know, Medicare is a guarantee. It's not a voucher. It's not a piece of paper. It's a guarantee. We've done that now, at least made a start with the chronic care additions to Medicare. But I think as we learn more about what the chronic conditions are all about and how to treat them, maybe we're going to learn some things about how to prevent them in the first place. And I'm going to want to talk to you about that relationship as well. Mr. Chairman, good work as always, and your leadership on healthcare is long noted, and look forward to working with you on the things we're talking about today.
Thanks, Chairman Wyden. I have a number of questions that I'll ask Dr. White. That creates a second round, so I'll recognize Senator Braun, and then I have another hearing to get off to. So I will close the hearing after those two rounds. Dr. White, CMMI looked at some programs that were cost savings failures and others that were cost savings successes. Your CMMI report notes models that produced statistically significant savings, and that a third of the CMMI models that produced statistically significant savings were ACO models. Your colleague, Mr. Kouros, on the panel being one example. You noted also that certain features of the Pioneer ACO model have been incorporated now into the Medicare Shared Savings Program, and that beginning next year, CMS has announced that the Medicare Shared Savings Program will also incorporate aspects of the other successful ACO model, the ACO investment model. What are the qualities of those successful models that led to their success, and where did those ACO models succeed in achieving savings?
Sure. Thank you for the question, Chairman. At a high level, MSSP has operated...
Let me interrupt you just for 1 second to say that Senator Kane has arrived, and I amend my previous order of proceedings so that after Senator Braun, we'll recognize Senator Kane.
MSSP has operated one-side models where participating providers can share in savings, and also two-sided models where providers can also incur financial penalties. And a key feature of the Pioneer ACO model was that it incorporated a two-sided risk arrangement for all participants by the second performance year. And the main MSSP program is moving toward those two-sided models. The ACO investment model, one of its key features was that it provided prepaid shared savings, which was intended to support investment in infrastructure and the formation of ACOs, especially in rural areas and underserved areas. Now, our report was at a fairly high level, focusing on budgetary impacts, so we didn't dig into the specific operational details of those, but the two-sidedness and the funding for infrastructure investments were the features of those two ACO models that stood out to us.
There were winners in those ACO models, and the winning features of those models are now being propagated further into the shared savings program, correct?
That's fair to say.
What do experts that CBO hears from say about the importance of primary care in the context of successful delivery system reforms?
Sure. I'll reiterate the fact that primary care is key to patient attribution in ACOs, but then more broadly, physician-led organizations have the ability and the incentives to move care away from high-cost specialty care facility settings and focus on management of chronic conditions that is consistent with the ability to save money and reduce spending.
And finally, is it correct that CBO communicated in a letter to our committee in March of this year that CBO now projects that the United States will have spent $6.3 trillion less between 2010 and 2033 than CBO's original projections proposed in its 2010 baseline?
Yes, and just to unpack that a little bit, this is from the letter that we sent in March of this year. Over the 2010 to 2020 period, we spent $1.1 trillion less on healthcare than we projected in August of 2010. And looking forward from 2021 to 2033, we now project we will spend $5.2 trillion less on major health programs than we projected in the summer of 2010. That sums to the 6.3 trillion.
Great. With that, I will make that letter a matter of record, and I will turn to Senator Braun and then Senator King.
Thank you, Mr. Chairman. We talked about hospitals earlier. They now occupy that biggest percentage of the healthcare dollar. Insurance, though, cannot go unmentioned. When I redesigned my plan to make it to where we haven't had premium increases in 15 years, through the kitchen sink and everything at wellness, created healthcare consumers at the time, insurance was never intended to take care of minor healthcare. Just like it doesn't work in any other area of insurance, it's for indemnification of a critical, unusual incident or issue. I don't think it was ever intended, it's evolved that way, to cover everything. Do we need insurance for primary health care, or should it go back to what it was intended for, indemnification against critical illness or an accident? I want to start with Dr. Fiedler. And why is that still a part of the system? It's kind of like the Darth Vader that keeps the glue of lack of transparency and everything there. And then Dr. Daphne and Dr. Caroz. So keep your answers at about a minute or so we respect the time. Dr. Fiedler, you can start.
So I think one of the rationales for coverage of some of these more routine services is that they have the potential to prevent the need for more expensive services down the road. And so I think
prevention is worth, an ounce of that is worth a pound of cure.
Right, and it may not be that they're cost saving, but it may be that the sort of benefits they provide together with the cost savings they generate means they're worth it on net. So I think that is
But that doesn't work in any other arena of insurance on minor stuff. Then you're mixing indemnification and the cash flow that goes with it, and you're doing other things to where why couldn't that be done directly between patient and the provider? and get rid of all the red tape and cost of processing a claim.
So I think another important reason that many of these services are being covered through insurance is because the insurer is actually playing a very important price negotiation function in the private market.
So I want to stop there. You've made your point. I think that is totally off base. You've gotten rid of what works in every other market. People shop around to save $50 on a big screen TV. They're not doing any of that. When I put that into my insurance plan, costs started going down by 50%. You throw the wellness tools, you have your cake and eat it too. Dr. Daphne.
Thank you for the opportunity, Senator Braun, to answer this question. I agree with you that insurance ideally does not have first dollar coverage, right? It's supposed to protect against the unanticipable risks that one has. However, what data show us is that when consumers have high deductibles, that they cut back on their care, but they cut back indiscriminately. They cut back on care that could reduce spending later on, and to the extent that employers and government payers then end up having to spend more because of those decisions early on, that's a reason to subsidize that kind of care.
To me, your question, at least in part, and I'll see if you agree, raises the question of how should primary care be compensated, and it seems like when you're moving away from the purpose of insurance as you described it, you could think about capitated models of payment for primary care that gives you a predictability in what the cost is. Exactly how that gets funded and what the incentives are for patients is sort of a different question, but I think that the cost of primary care should be relatively predictable, and that paying prospectively on a per member per month, per member per year basis for primary care makes sense. One of the things that I would add is that I think there is value in having primary care have skin in the game in terms of managing total cost of care, because I believe that they play an important role in that, although they can't do it alone.
I think that is the dilemma, because you do then eliminate the market and that skin in the game, and we've evolved that way. All I can tell you is I'm seeing more and more, unless you're saying people would not take care of their own well-being just because that's the way it's been, I think you're sticking to a model that's broken and that has gotten us where we are today. We need to get creative there. You bring healthcare costs down. I did it, and it's been working for 15 years, and we got to be more creative, entrepreneurial in areas like that. Mr. Merkel, you want to weigh in quickly?
Yes, I would say that you're right. Insurers' raison d'etre is to insure against financial risk, and to the extent that we have required them to do more, they do that inefficiently. And while, yes, currently they're playing a role to negotiate prices, I think that they haven't done that particularly well. And if we put more pressure on through giving consumers and patients and providers more active role in doing that, I think we'd probably see better results in the long run.
Thank you to all the witnesses for being here today and helping the committee examine ways to both maintain quality but reduce costs as we're doing so. I care very deeply about this topic. I have a bill with Senator Bennett that I call the Medicare X Choice Act, and I want to talk about it a second. Dr. Fiedler asked you a question about it. Medicare X Choice Act would create a public option that would expand upon the successes of the Affordable Care Act, making affordable coverage available for families, individuals, and small businesses. It would direct CMS to devise an insurance policy that would cover the ACA essential benefits and offer that policy on the exchange for individuals and small businesses. An individual choosing to purchase that policy, if they qualified for the ACA subsidy, could apply that subsidy to bring down the cost of the premium, because the CMS devised policy would not need to cover a profit margin, fancy salaries, ads on TV, return to shareholders. It would likely be a very affordable option for people, wouldn't force people to buy a government policy, but I think folks looking at the exchange would find it to be a very attractive option. The proposal would increase access to health care services in parts of our country that have historically faced challenges accessing care. Rural Virginia, rural America, where often there's inadequate options or choice on the exchanges. People, because CMS exists in every zip code in the country. It could be available on every exchange in the country. Somebody moving from Virginia to Oregon, not knowing whether the insurance company that insures them in Virginia even offers policies in Oregon, would need to worry about whether the Medicare X policy would be available because Medicare already operates in every zip code. My colleagues and I have differing opinions about how to achieve the goal of broadened access and reduced costs, but I do think we have the common goal of doing those things. And that was why I was so gratified when the Urban Institute issued a report last year stating that if implemented, the Medicare X Choice Act would reduce the number of uninsured people by about 1.1 million, save households about $10.9 billion a year, save the federal government $20.3 billion a year, and cut total spending on health care by $456 billion over a 10-year period. Increased access to care is not only good for individuals, it's good for communities. Dr. Fiedler, I'd like to ask you to speak about how the mechanics of Medicare X would both increase access to care and reduce health care spending over the long term.
Yes, thank you for the question. So this is something that Dr. Daphne alluded to in her testimony, but a striking feature of our healthcare system is that private insurers pay much higher prices for the same healthcare services than Medicare does. And that's a reflection of the fact that private insurers have to negotiate these prices with providers, and providers in many markets wield a lot of market power. Whereas Medicare is able to pay lower prices by setting prices administratively. So Medicare X would introduce a Medicare-like plan into the individual and small group markets, and because Medicare X would pay these lower prices, it would offer lower premiums than existing plans. It would probably, because of the lack of a profit margin and probably somewhat lower administrative costs, that would add to the premium reductions. So that's where the cost savings would come from. You also asked about access. In terms of access, there would be sort of two main effects to think about. One is that the lower premiums would cause some people who are uninsured today to take up coverage, which would improve their access to care. And then another is that the federal government would save a lot of money on the subsidies delivered to people who are currently insured. And the bill would then use some of those federal savings to enhance the subsidies available to people who buy coverage on the marketplace, and that would pull additional people into the market, into coverage, and improve access to care.
Thank you, Dr. Fiedler. We don't have the votes to do Medicare X yet, but I believe it's the next step forward that we started on a path with the Affordable Care Act. I don't think we should just go on a different path, but I think we should take the next step forward on the path we began. And I think offering a Medicare X policy on the exchanges and allowing people, as they shop, to do what Senator Braun said, to shop and try to find the most economical plans, I think that would be a good thing. Dr. White, I have a question for you, and then we will close the hearing. At a Budget Committee hearing last month, I asked Dr. Marilyn Moon about a New York Times article that caught my attention, and I heard Senator Whitehouse referring to it. The article was entitled, "A Huge Threat to the U.S. Budget Has Receded, and No One is Sure Why." And it was sharing the work of the CBO that between 2010 and 2020, Medicare costs were 9% lower than expected. The article was interesting in advancing different scenarios. I asked Dr. Moon if she had thoughts about why this happened, and she speculated two factors. One, that passage of the Affordable Care Act and an increase in people having insurance prior to joining Medicare might mean that people were a little bit healthier when they joined Medicare, and thus their expenses might have been lower, at least initially. And then she also pointed out that there was a demographic aging bubble of a lot of people turning 65 at once, baby boomers like me. I turned 65 in February. And younger seniors tend to be healthier than older seniors, so if you have a huge bubble of young seniors coming into Medicare, that can also affect costs. Given that CBO was responsible for the work that has led to this interesting phenomenon and speculation, can you talk about the factors that CBO took into consideration when doing the analysis and how those factors could potentially change over the next 10-year budget cycle?
Sure. There's a lot to unpack in that question. Let me start with the baby boomers aging into Medicare. That's a demographic phenomenon that's very well understood. It's very predictable, and it's baked into our demographic factors. So that is pretty straightforward to have a handle on. In terms of people having health insurance under age 65 because of the ACA and then aging into Medicare, that sounds plausible. We haven't dug into that and pinned down the size of that. The ACA did so many other things, big things in Medicare that that phenomenon, my sense is relatively small. But one thing that I want to draw out is that the unexpected slowdown in Medicare spending actually started appearing well before 2014, when the coverage expansions went into effect. And so this is really a long-running slowdown phenomenon. We know that we overestimated Part D spending. We know that Medicaid spending on long-term services and supports has turned downward. We're taking those factors into account when we project going forward. And I want to make a general point that we use the most recent historical evidence as our jumping off point. We look at our misses, we scrutinize those misses. When we come to understand our misses better, we explain to the world why we've updated our thinking. That showed up in the CMMI report in a big way. And our projections now, as always, we're trying to be in the middle of the distribution. It's likely to be too high as too low. The future is always uncertain, but we're trying to take on what we've learned and really dig into the phenomenon that Dr. Moon highlighted.
Well, great. Well, thank you, Dr. White. The fact that the CBO manages to make Democrats happy or unhappy and Republicans happy or unhappy. You know, I've railed at some CBO studies and been entirely comforted by others, and everyone around this table feels the same way. I think you're approaching the work that you do in this space with intellectual and integrity and an attempt to be even-handed, and I appreciate that. And I do think it's important. I applaud analyzing your misses, because when you miss something, going back and trying to understand why gives you the ability to calibrate and then, hopefully do a better job. I think the Samuel Beckett line is, ever tried, ever failed, no matter, try again, fail better. And so it sounds like that's the method that you follow. The hearing is now concluded. I want to thank the witnesses for appearing before the committee. Your written statements fully will be included in the record. Without objection, I submit statements for the record from Millbank Memorial Fund, the Rhode Island Quality Institute, the National Association of Accountable Care Organizations, from Professor David Cutler and Nikhil Sani, and a preprint publication in Health Affairs titled, quote, "Active Steps to Reduce Administrative Spending, Associated Financial Transactions in U.S. Healthcare." As information for all senators, questions for the record are due by noon tomorrow, with signed hard copies delivered to the committee clerk in Dirksen 624. Email copies will also be accepted. We'll ask witnesses if there are questions for the record that are submitted to respond to those questions within 7 days of receipt. With no further business before the committee, this hearing is adjourned.